Welcome, viewers of your award-winning Let's Talk America Radio. I am Shayna Thornton, on-air host and executive producer, and welcome back to another edition of Real Talk. It's our video series that we have on Facebook and YouTube and Instagram, where we spotlight the trending topics you want to know more about with the best and the brightest experts and advocates out there. And tonight's edition of Real Talk certainly is no exception. We have a friend of our program back on. It's been several years, but we're talking about a topic so many women want to know more about, and we're talking about fibroids with the one and only Dr. John Lipman. Dr. Lipman, welcome back to Let's Talk America Radio.
Well, thanks very much for having me. It's nice to see you again.
Great seeing you, sir, as well. And so we're going to dive right into it. But before we do, we have a tradition here on our video series, Real Talk, Dr. Lipman, where we ask our experts, such as yourself, what really drives you to be the expert in the field that you're in? Now, I've seen your CV and your bio, and it's quite impressive, all of your medical training. But you specifically, of course, specialize in uterine fibroid embolization. And we're going to define that much more in a few minutes. But you're a trained radiologist, you're technically an interventional radiologist, but why and what had you so interested in really trying to help so many different women with giving them another option other than hysterectomies?
Well, the procedure you mentioned, uterine fibroid embolization, UFE, is what I am known for, and it's a tremendous procedure. And what drives me is the fact that so many women don't know anything about it that are suffering with fibroids. There are over 1 million women in the United States right now on the sidelines suffering with fibroids. They don't want surgery. They've only been told about hysterectomy as their only option. They don't want it, and so they suffer with it. In fact, I spoke not long ago at Tuskegee University, and I met 3 women under the age of 30 that had already had a hysterectomy. They got tired of the suffering month after month. They weren't given any other options. And so they had a hysterectomy. And when they heard my talk about UFE, they came up afterwards in tears. And so I don't want to meet any more women under 30, well, really any age, that doesn't want hysterectomy and ends up succumbing to hysterectomy, not knowing about this tremendous UFE procedure. So I'm out there every day talking to everyone throughout the country about how great this procedure is. It's been around a long time, and it's long overdue that, you know, women are entitled to know all their options, and hopefully everyone soon will know about UFE.
Yeah, thank you so much for your advocacy and certainly educating so many different individuals. Let's dive right into it. And for those that are just joining us, you are watching Real Talk edition from Let's Talk America Radio. And we are putting the spotlight on your health. In particular, we're talking about fibroids that so many women from so many different backgrounds have suffered with. And we have an expert on with us, and he is educating all of us on options other than hysterectomies. Okay. And so, of course, this information is general health information for you. For specific information, we do ask that you consult your own medical provider. But Dr. Lipman is going to be such a wealth of education, as he always has been. Dr. Lipman, let's go right in. Exactly. There may be a guy or a woman listening in and say, well, I've heard fibroids mentioned before, but what exactly are fibroids? Who do they affect? And how exactly does it affect the body? Does it always cause pain or a disruption in the body's function?
Well, fibroids are a benign tumor, so that's first and foremost. It's not cancerous, and it's the most common pelvic tumor seen in women. And it's, as you mentioned, it's a particular prevalence in women of color. African-American women suffer with fibroids more than any other racial group. So 1 in 3 women have fibroids in general, if you look at all races, but up to 80% of adult African-American women have these benign tumors, and they're hard and firm. They're like rocks, and sometimes women can feel them through the skin. It can make them look pregnant. And they cause symptoms based on where they're located in the uterus. Those that are located very central, right up against the lining, will cause heavy menstrual bleeding. In fact, fibroids are the #1 reason why women have heavy periods. If they're located in front of the uterus, the bladder sits in front, and it can act like a paperweight. And so the bladder gets compressed by these rocks. And so the woman ends up urinating more frequently and waking up at night to urinate. If they're located laterally, they press on pelvic nerves to cause pain. If it's in the back of the uterus, it can cause low back and buttock pain like sciatica from low back strain.
Okay.
If it's near the cervix, it can cause painful intercourse. So there's lots of symptoms from these fibroids. They cause a lot of misery. And it's important to recognize these symptoms as being abnormal. Sometimes women can bleed very heavily for a long time and not realize that's not normal. But it is the number one reason why women have these heavy periods, and they're often what presents to the doctor with this symptom.
I have to ask this. I mean, you did mention that a lot of women will have heavy periods. I would imagine there's a link between perhaps heavy periods and anemia.
Yeah, the more blood you lose each month and the more you have these abnormally heavy periods, you start running deficits like our government with money, and you just can't replace it. And no matter how good your nutrition is, even if you supplement, it's hard to absorb iron orally. So the more and longer that you do this heavy bleeding, the lower your hemoglobin and iron become. That's the definition of anemia, this low iron, low hemoglobin. And hemoglobin carries the oxygen around our red cells around our body. And so some of the symptoms of anemia are being very fatigued,
Okay.
tired, weak, and it gets progressively worse. And sometimes people don't recognize that as abnormal because they attribute it to, oh, I'm getting older, or it happens so slowly over time. It kind of creeps up on them and they don't realize that it's not normal to feel tired and weak each month. They might get lightheaded or dizzy. They might get migraine-like headaches. They could chew and crave ice. That's a big one. When I ask patients about that and they say, wow, yes, how did you know? They think I'm clairvoyant. Well, these are the signs of anemia.
Yeah.
Hair loss, even brittle hair loss. I tell them that unlike my hair loss, which is permanent, this is due to anemia and it'll grow back. And so a lot of times patients will be on iron therapy, but iron therapy is just like bailing water over a sinking boat. It might keep you afloat for a while, but you got to treat the culprit. So you got to fix the problem, and the problem which is causing the heavy periods, the fibroids, need to be fixed.
Yeah. Thank you so much for the great information. I do want to highlight one thing you said. 1 in 3 women have fibroids, but over 80% of those women tend to be African Americans, which begs the question for me, is it genetic? If mom or aunt or sister has fibroids, does that necessarily mean that a woman will as well?
Well, if your mom has fibroids, you are much more likely to have them too. So there is a genetic component to it, but it's also lifestyle too. Nobody knows where fibroids come from, but once they arrive on the scene, they grow with hormones, estrogen in particular. That's why they grow rapidly during a pregnancy and why they tend not to be an issue for most women once they're in menopause. And so we try to do an anti-estrogenic approach, if you will. So estrogen is produced and stored in body fat. So while you can't pick your parents, you can't do anything about the genetics, you can try to be as close to your ideal body weight as you can, shed those excess pounds. In general, African-American women have more body fat than other racial groups. It's one of the reasons why they have fibroids more than other racial groups. There are some hormone-rich foods, red meat, non-organic chicken, dairy. We try to have patients try to moderate that or eliminate it if they can. Eat more colored fruits and vegetables. Colored fruits and vegetables have flavonoids in them, which block an important enzyme in estrogen production. And then lastly, vitamin D. Vitamin D is actually a hormone. It's not a vitamin technically, and it's the most powerful anti-fibroid growth hormone we have. And only 10% of African-American men or women have adequate vitamin D. And we get vitamin D through absorption of the skin, and the darker the pigmentation of your skin, the harder it is to absorb adequate vitamin D. And so it's, again, another reason why African Americans have more issues with fibroids. And one other thing that's not as much of a problem these days, I've been treating fibroids for over 25 years, but back in the day, before nowadays women wear their hair more natural, but back in the day when there was a lot of hair relaxer use, if you look at the main ingredient in hair relaxers, it's biochemically almost identical to estrogen. And the scalp is very vascular. And so essentially you're kind of burning this stuff into the bloodstream. And any exogenous estrogen
Okay.
is going to stimulate fibroid growth. Even birth control pills, which is one of the things gynecologists use to treat when somebody has heavy periods, that's one of the first things used. So it's that's kind of a double-edged sword, because on the one hand, it will lighten flow for at least a little while, but in the background, it's growing these fibroids more rapidly due to the extra estrogen.
Wow, such great information that you are sharing with us here on Let's Talk America Radio, talking about fibroids one-on-one with the one and only interventional radiologist, Dr. John Lipman, out of Atlanta, Georgia. He is the founder and medical director of the Atlanta Fibroid Center, and he is really educating us and also encouraging all of us to really know your options. I want to discuss something else before we go into the solution of treating fibroids. You talked about obviously it being prevalent in women of color, in particular African-American women, but how early can fibroids show up, Dr. Lipman? Because as you know, there are many young women around the world right now that can start menstruating as early as 10 or 11 years old, sometimes earlier if you talk to some pediatricians. But how early do they start to notice fibroid growth?
Well, African-American women not only get fibroids more commonly than any other racial group, they get them earlier in life. They tend to be bigger and more numerous, and they're more likely to get a hysterectomy than other racial groups. Incidentally, if you look racially at who gets hysterectomy, African-American women get it for fibroids, which are benign tumors. Caucasian women get hysterectomy for cancer, which is appropriate. And we do way too many hysterectomies for benign disease, and we can get into more of that in a moment, but they can come early in life. In fact, the few teenagers I've seen that have suffered with fibroids, they're all African-American teenagers because they get them earlier. But it's something that everybody needs to know about. The treatment for fibroids, you try not to be too aggressive with young women. So that's a challenge when you have a young woman who's got significant fibroids, but they usually arrive a little bit later in life, usually for women, say late 20s, 30s, 40s, even early 50s. That's the kind of time horizon. But every now and then you'll see a woman under 20, a teenager, actually have fibroids. And that's a real challenge.
I mean, you laid out a great story for us in terms of how fibroids can be problematic, from anemia to pain or discomfort. And you did mention briefly, I want to harp on that a little more, about in pregnancy, there can be a tendency for fibroids to grow much quicker because of the high estrogen that, of course, pregnant women are carrying as they carry their baby. I would imagine that can be problematic in terms of disrupting the normal growth of a uterus as the baby continues to grow.
Yeah. Fibroids can cause problems with any part of the fertility journey, from conception all the way to delivery. But fortunately, most women with fibroids will have uneventful pregnancies. So even if you have fibroids, it's not meaning you're not going to be successful, or you're going to definitely have problems with the pregnancy. Most have uneventful pregnancies, but fibroids can interfere every step of the way.
I see. So important to know. Education is key. Now let's talk about the solutions. And before you get started on explaining thoroughly uterine fibroid embolization and what exactly it does, and talk about the safety of it, and talk about some drawbacks to it as well. But one, a hysterectomy, there may be a man or someone, a woman listening to you, or a young teen, and saying, what exactly is a hysterectomy? Break that down for us. And what exactly is removed? I happen to know there are different types of hysterectomies as well. Tell us more.
Hysterectomy is removing the uterus. And there, as you said, there are different types of hysterectomy. There is what's called the supracervical hysterectomy. That means everything above the cervix is removed. They leave the cervix behind and take everything else. So sometimes people have not only lose their uterus, but they might lose their ovaries and fallopian tubes, kind of total hysterectomy, versus just taking just the uterus itself, or in some cases I mentioned, everything but the cervix. So there are different gradations, but hysterectomy is the second most common surgery performed in the United States, which is rather surprising because half the population doesn't even have a uterus. And the most common reason why we do hysterectomy in this country is not for cancer, which would be appropriate. It's for these benign tumors. And the average age of hysterectomy is less than 40, 39. And so these are young women. As I said earlier, I've seen too many women less than 30 have already had a hysterectomy. They didn't want it. None of them wanted it, but none of them knew of these non-surgical options like UFE, where they wouldn't have to have any surgery whatsoever. So that, I guess my key point in all of this this evening is to, no matter what your gynecologist tells you, if you are suffering with fibroids, you do not have to have a hysterectomy. Hysterectomy should be the absolute last resort, not the first and only option, which is typical when women seek out options for treatment.
So key. That's important to note. I also want you to paint a picture very clear. And obviously, you're an interventional radiologist. You're not a gynecologist, OBGYN that's doing hysterectomies, but make it clear, hysterectomies, they are major surgeries, right?
Oh,
I mean,
I'm surgery.
Yeah.
Now, you might hear of minimally invasive hysterectomies where it's done laparoscopically, either from a regular laparoscopic hysterectomy is when the surgeon holds the instruments and they operate through these metal straws.
Okay.
Then there's the robotic hysterectomy where robotic arms are holding the instruments. Again, it's still surgical. They're cutting into the person's abdomen and then cutting into the uterus and chopping it up and removing it. Yeah. Then, unfortunately, even though those are minimally invasive surgeries, the vast majority of surgeries that are done for hysterectomy are what is called open hysterectomy, which means either a horizontal incision from one hip to the other. That's for uteruses that are at the belly button or below. And when you get above the belly button, they can no longer do horizontal. It's from breastbone to pubic hairline vertically. And sometimes they try to do horizontal and they can't get the skin up high enough. So then they end up doing the vertical too. So now you have this upside down T, which is really brutal. So the surgery is extensive, and there's lots of things that could happen intraoperatively during surgery, nicking important structures, whether nicking the bowel, nicking ureter, nicking bladder, bleeding, causing transfusions, wound issues, you name it. But what the surgeons don't mention to women, which is also really important, is what happens to a woman when she loses her uterus. They often don't talk about that.
Correct.
And so there are a number of things that happen to women after. A number of them struggle psychologically, like a man being castrated, because it's the epicenter of their womanness, and there's no way to predict who that's going to be. There's a lot of women that struggle sexually, loss of libido, loss of orgasm. And it's embarrassing, and no one wants to talk about these things, but they're real. There's a lot of urinary leaking after hysterectomy. You take this really big, rock-like, enlarged fibroid uterus out of the pelvis, and now you've weakened the pelvic floor muscles, and she leaks urine. And I challenge anyone to go to their Publix, Kroger, or wherever they sell adult diapers and go and look and see who's on the packaging. Who you should see on the package of an adult diaper is someone like my dad. My dad is 95, and that's who you should see, but you won't see him on the package. Who you'll see is likely someone in their 30s or early 40s of African-American woman in that age group. That's who you're going to see. Why? Because the average age, as I mentioned, a hysterectomy is 39. So these are young women, and that's the target. And it's like, in fact, I have an advertisement in my office from Depends, who's the big adult diaper person. And they have very expensive deep pockets for marketing. So they know exactly who they're targeting. And I have an ad that has this really attractive, thin African-American woman, probably late 30s or so, and she's scooching on her skinny jeans over her adult diaper. And it has some cutesy kind of slogan or something, they'll never know what you're wearing. Or it's like, I look at that picture, I'm like, what in the world does this woman need to wear a diaper for? That's what they should be asking. And so there are a lot of issues with hysterectomy. And it's, again, if you have uterine cancer, hysterectomy is appropriate, period, end. But for benign disease, why are we essentially amputating women of color for benign disease? It should stop right now.
Thank you so much. You're sharing some great information. Of course, this is to educate and empower you with your options out there. We're putting the spotlight on fibroids and talking about uterine fibroid embolization, which we're going to hit right now with the one and only Dr. John Lipman. He is the founder and medical director of the Fibroid Center out of Atlanta, Georgia. Very well-known interventional radiologist rather. And I did want to mention as well, he's an adjunct assistant professor at Morehouse School of Medicine in Atlanta, Georgia as well. So he comes highly recommended, and he certainly is an expert in the field of fibroids and talking about uterine fibroid embolization. Let's go there, Dr. Lipman. I want to touch on that certainly before we wrap up tonight. Now tell us, what exactly is UFE and who actually can benefit from it? Who is the ideal patient? Because I know you're an advocate for it. You're an advocate for women knowing their health options out there. But I know you also do, I've spoken with you before, there are reservations for a group of women perhaps who may not be that ideal patient. Help us out.
A lot to uncover, but uterine fibroid embolization, UFE, is the same procedure as uterine artery embolization, UAE. They're interchangeable. The procedure got discovered in around the early 1990s. We had been embolizing cancerous tumors for many years, trying to make it an easier operation for the patient and the surgeon. Certain tumors like kidney cancer, for instance, is very vascular, lots of blood vessels. It bleeds a lot. And so we can go in pre-operatively and cut the blood supply off to the cancerous tumor of the kidney and make it an easier operation, an easier time to remove that kidney for the surgeon and the patient. Mm-hmm. Somebody got the bright idea in France in the early 1990s. Well, why don't we do that prior to hysterectomy for fibroids? Fibroids are very vascular tumors. They're benign, but they're also very vascular. It might make an easier operation for the gynecologist. So they started doing that in France. Well, in France, they don't have the system, the medical system we have here. When I embolize a cancerous tumor, they're in the operating room an hour later. In France, it's socialized healthcare, socialized medicine, rationed healthcare. So they would get their embolization, and then they would be discharged home, and they would have to wait for their hysterectomy because it's an elective thing. It's not something emergency. So they would be at home 6 weeks, 7 weeks, 8 weeks, waiting for their hysterectomy. Well, what happened? Their symptoms went away. So these women started calling up their gynecologist in France saying, I feel great. My periods are light. My pain's gone. My urinary frequency stopped. I'm sleeping through the night. All of my fibroid symptoms are gone. Do I need this hysterectomy now? And the answer was no. You didn't need the hysterectomy at all. All you needed was the embolization. So they started doing that here in the United States in the mid-1990s. And I happened to be at the presentation of the first 11 patients by Scott Goodwin, who did the first USA case of a fibroid embolization. And I'm in the audience going, wow, I'm in Atlanta. I better take this back to Atlanta. And I started doing it in Georgia. And we have the largest experience now, over 10,000 women we've embolized. It's a tremendous procedure. It basically, you want to get into the blood supply of the uterus. There's a uterine artery on each side, and each of those uterine arteries branch like a tree, getting smaller and smaller branches. The leaves of the tree are like the fibroids, and I know what size those tiny branches are, and I can plug them up. The big trunk and the main branches of the uterus stay open, so the uterus stays alive, and we've had numerous children born after UFE, in fact, multiple sets of twins. So the uterus is alive, but every fibroid, no matter how big, how many, where they're located, hopefully they're all dead. And as those fibroids die, they soften and shrink. And as that softening and shrinking of the fibroids occurs, a woman's symptoms start to go away.
I see. Wow.
So
covers a lot, so it shrinks. It doesn't necessarily, I guess, takes away the juice from the vascular part, but it doesn't necessarily disappear, correct?
Well, it can. We've had the shrinkage really is almost irrelevant. It's great when they shrink to nothing and they disappear completely. That's always great, and we do see that. But it's all about them being dead, because if they're dead, they don't cause any symptoms. Most women that have fibroid tumors in their uterus have no symptoms. They don't need to see me. They don't need to see anyone. They don't need their fibroids treated because there's no symptoms. And so we call those fibroids passenger fibroids. They just kind of ride along in the uterus, and the woman will pass away with them one day.
Okay.
Most, the women that we see at the Atlanta Fibroid Center, they have significant symptoms, heavy periods, pelvic pain, what have you. Those are not passengers, but what we do with the UFE is we convert those fibroids, hopefully, into smaller dead passengers that will never bother a woman ever again. So it doesn't matter how big, how many. If you've been told you need a hysterectomy for fibroids, get a second opinion from an interventional radiologist, because likely, almost assuredly, you'll be a candidate for UFE.
Yeah. I had heard, and I know we spoken some years ago about when it comes to UFE that there were some individuals who were saying it was a great option, but it wasn't necessarily for women that still wanted to have additional children. And I know you mentioned that in your practice, you've had women who've gone on to certainly conceive and birth healthy children. But where does it stand on that, the literature and the recommendation, if a woman is looking to get obviously UFE, but she still wants another child?
They're both myomectomy, which is the surgical option, and UFE are both in play. And you have to really look at the individual person. It's not like you can't, although there are gynecologists who will tell patients, if you're interested in children, you can't have UFE, and that's just false. The chance of having a child after UFE is every bit as good as myomectomy. In fact, 60% of our patients that wanted children got children, which is excellent because our patients tend to be older. By older, I mean like 35 to 45. Those tend to be the ones in that range that are interested in fertility. While a lot of, myomectomy fertility patients are much younger, in their 20s. And so it's a longer discussion. You have to find out how old the patient is, because with age, woman's fertility diminishes. Okay. Has she ever had a myomectomy before? The biggest problem, or one of the big problems with myomectomy, is they rarely get the tumors out, all of them. In fact, a lot of times they don't even get half of them out. So almost, most of the myomectomy patients wake up with living fibroids in their uterus, and they're going to grow. And there's an 11% per year rate of recurrence. So that means over half the women that get myomectomy will need another procedure within 5 years, a third of them within 3 years, versus UFE that should knock out all the fibroids. So the recurrence rate is very low for UFE and relatively high for myomectomy. The other fertility difference is that if you get a myomectomy and you get pregnant successfully and you deliver, you're not going to deliver vaginally. You're going to get more surgery. I said hysterectomy is the second most common surgery in the United States. If you get a myomectomy, you will get the privilege of the most common surgery done in the United States, which is a C-section. Our births are typically full term and vaginal. And so it's, again, another important difference. And it's a lengthier discussion. You have to know, if anybody's ever had one myomectomy, they should never have any more than one. The next thing that's done should be a UFE. So it depends on if they've had previous surgery, how old they are, how many fibroids they have. By MRI, we use pelvic MRI, not ultrasound. Ultrasound is what's commonly used, but it vastly underestimates the number of fibroids. And so if you've got to do a myomectomy and you're surgically have to remove them, if you have 50 fibroids in your uterus, probably not a wise thing to do a myomectomy. UFE is much better. But if you truly by MRI have only 1 or 2 fibroids, okay, maybe myomectomy might be the better way to go. So it's not one size fits all. It depends on a lot of factors. And that's why it's important to go to an interventional radiologist that has a lot of experience in UFE to truly see if you're a candidate and what the risks and benefits are. And then make the choice best for you.
Yeah, that's so key. And it's about education. What Let's Talk America Radio is trying to always put out to our listeners and our viewers. I have to ask you this. It's a balanced conversation here on our program. What are some of the risks or perhaps side effects, if you will, of the uterine fibroid embolization?
Well, our patients that come into the Atlanta Fibroid Center that have UFE, it's a 30 to 40-minute procedure. There's about a 3 or 4 hour recovery, and they're discharged home with a Band-Aid. That's it, a Band-Aid, and their uterus, by the way. And so the risks of a procedure where you're going home the same day with a Band-Aid, with no general anesthesia, with no hospital, obviously pales in comparison to the risks of surgically putting you to sleep and surgically cutting you open and doing myomectomy or hysterectomy. But any procedure has risks, but obviously the risk of UFE are not only much less frequent, the risks that are present are much less severe. But there are two main risks. Some women don't menstruate permanently after UFE.
Okay.
Now, I have done 10,000 or so UFEs, one of the largest, if not the largest experience in the United States.
Okay.
I've never seen anyone under the age of 40 where that ever happened. As you get above 40, you start to see some women that won't menstruate permanently. 40 to 45, about 1 to 2%.
I see.
46 to 50, now you're talking about 5 to maybe as high as 10%. And 50 and above, maybe 10 to 20%. So as a woman gets closer to her menopausal age, the risk increases. But fortunately, nobody under 40 has that ever happened to. So that includes most of the people that are interested in fertility. There's about a 5% chance of passing some fibroid material vaginally around the time of the menstrual. And it's totally fine. It's just important to know that that can happen. It's different than blood or blood clots, which our patients have seen. This is kind of fleshier, like tissue. And on rare occasions, 25 times out of 10,000, we've needed the gynecologist's help to actually deliver some of that material out. So it's much safer than surgery. UFE is much less invasive. The recovery is much shorter. The recovery is about 5 days or so. And importantly, you get to keep all your parts.
Yeah, so key knowing the options that you have, and this has been such a great conversation, one that I know has many patients informed. There's been curiosity. I think we all know women in our family or friends or at work that have suffered through with fibroids, and often the only option they were ever told was hysterectomy. So certainly here is another option out there, which very glad to have that information as well. For women that are suffering and they're like, well, you said it was connected to estrogen. I want to ask you really quickly about menopause, because obviously as women get older, they're closer to their menopausal age, estrogen goes down. I would assume that helps cut down on the likelihood of the growth of fibroids, Dr. Lipman, is that correct?
That's absolutely correct. So for most women that are suffering with fibroids, if you can get to menopause, for most women, that will take care of the problem. However, we do treat a number of postmenopausal women. It's often for urinary frequency, because these big fibroids, while they're not having periods anymore and they no longer suffer with heavy bleeding, they still have this big rock on top of their bladder, which makes their life miserable. Their bladder is not allowed to fill to capacity, and so they urinate more frequently, often wake up in the middle of the night, and it's very disabling to them, and so we'll treat them on that basis. There are other women that will take hormone replacement therapy or getting exogenous hormones. So while the ovaries are kind of ceasing estrogen production, the woman is consuming exogenous estrogen and keeping that estrogen going. So for most women, if you're postmenopausal, your fibroid saga is over with, but we will treat on occasion some postmenopausal women with UFE.
Yeah. And I know it varies from woman to woman. Obviously, a lot of it has to do with family history and her mother's own age when she went through menopause. But what's the average age that you see women going through menopause? Is it mid-50s?
Yeah, somewhere in their late 40s to early 50s. I'd say the absolute is probably between 50, 51, but late 40s, early 50s in that usually. Now, every now and then we'll see somebody go well beyond that, even late 50s occasionally.
Wow. Such great information here with the one and only interventional radiologist, Dr. John Lipman, medical director and founder of the Atlanta Fibroid Center. This conversation was eye-opening. I've done health reporting, as you know, with you, but every time we have you on, we continue to learn, and that's what it's all about. Dr. Lipman, do you have any lasting words of hope or encouragement for a woman out there? Perhaps she's already had a hysterectomy, much to her disgrace, that she did not want it, or perhaps there's a woman who's being told right now by a gynecologist that that's the option. You need to come on, you need to hurry up and have it. What would you say? Because you're a physician, right? I'm a health reporter. And so you and I may have the confidence and the skill set, and obviously you're a medical doctor, I'm not. I don't play one on TV either, Dr. Lipman, but we have to ask the right questions, because this is our body and we have the right to ask. But you and I both know there are many people who are intimidated often when a white jacket or white coat comes into the room.
Right.
Your words to that woman, or even a man, if he's listening, not with fibroids, but other issues, and he's intimidated.
I think it's very important for everyone to be their own advocate. No one knows your body better than you. And if you go to a physician and you have apprehension like that, and there are many reasons to have that apprehension, particularly women of color, based on our history, particularly in the South, and the Mississippi appendectomies and Fannie Lou Hamer and all that. So bring a person with you so that they can help support you. Make sure you come with questions. Don't just go in blind. You've got questions, write them down, and make sure you ask your doctor about these questions and have somebody with you to help be your advocate if you feel, sheepish or apprehensive in any way. And if you feel like you're not being listened to, if you're being dismissed, or you bring up symptoms like your period or whatever it is, and you feel that the doctor is not giving you the appropriate time or is dismissing you, find another doctor. Period. Do not accept that. It's very important. If you're a woman suffering with fibroids and all you've heard about is surgery, and it's really important to know you do not have to have hysterectomy for fibroids, no matter what your doctor says. UFE is one of the biggest medical breakthroughs. It's well proven safe and effective with a long track record of safety. Find someone that can help you with that. And if you're a woman that's already had a hysterectomy for fibroids, we certainly feel for that situation. You can still make lemons out of lemonade, or make lemonade out of lemons, by sharing your story and your experience with other women. And you may know about UFE now. In fact, a supermodel, Beverly Johnson, who's here in Atlanta, she's first African-American woman on the cover of Vogue. She was in that very situation. She went to her doctor. Her doctor only gave her hysterectomy. She didn't want it. She dragged her feet, as a lot of women do. She tried to get to menopause. She just finally gave up and had a hysterectomy, and had some really significant negative consequences, some horrible side effects after her hysterectomy. And then she finds out about UFE, and she's really upset. And she's gone around the country advocating for women to know their options, to know about UFE. In fact, she was on the Today Show with one of my patients saying, I wish I had done more of my own research and been my own advocate. I didn't do that. And I really feel like everyone should do that. Yeah. I can't talk about UFE, but listen to this woman and you can hear her story, because UFE is a tremendous procedure, and you can share that information even if you've had a hysterectomy.
Yeah, it's all about your options. Education is key. And that's why we wanted to put this interview out, put the spotlight on this topic, and bring you in to explain it. Of course, general information again to our listeners and viewers. Please speak with your own provider about specific concerns with you, but you have the knowledge. And like Dr. Lipman said, even if you have to bring a family friend or someone in your village with you to write those questions down, it is your body and you have to take ownership of it. And no one can do that for you but you, right? And that's why it's so important.
And women are entitled to know all the options. They go to their gynecologist because they're the gatekeepers of women's health. And the gynecologists are obligated to tell women not just the surgical options, all the treatment options, including UFE. But unfortunately, many studies have shown most don't live up to that obligation. they only mention the surgical options, which they do. They all know about UFE, and they need to inform their patients about all the options. It's not ethical, it's not right.
Such great conversation, one that will likely be continued around the dinner tables and at the water cooler tomorrow at the job. Dr. Lipman, where can our viewers and listeners go for additional information about uterine fibroid embolization and the work that you do?
Well, there's a lot of ways. Our website is atlii.com, atlii.com. There's lots of information there, and they can even make appointments online. We have a YouTube channel, Atlanta Fibroid Center. So if you go to YouTube and type in the search Atlanta Fibroid Center, you'll see over 150 videos on fibroids, on UFE, on the work we're doing. We have an Instagram page, dr_ my last name. So it's dr_ Lipman. And if they want to do the old fashioned way, pick up the phone and call our office 770-953-2600.
Awesome. Dr. Lipman, thank you so much for being on with us on Real Talk, produced by Let's Talk America Radio. I am Shana Thornton. Super excited that you joined us on tonight's edition. Stay tuned, because your health is your wealth, and we'll continue to keep you educated and informed on so many topics, be it your health, fibroids, is it cancer, is it vitamin D deficiency, is it heart disease, diabetes, is it educational options for your children, or if we're talking about the latest laws that impact you and your community. Stay tuned in. Let's Talk America Radio offers real talk for real people. That's you. Stay safe, America, and we'll be back on soon. For additional information, please feel free to visit ltaradio.com. That's ltaradio.com, or find us on your favorite social media outlet. Simply use hashtag LTA Radio. That's LTA Radio, lowercase or all caps. Take care. Dr. Lipman, we appreciate your information and your time, sir.
Thank you very much. It's nice to see you again.
Yes, sir.